Very good morning, everybody. Dr. Pradeep Srinivasan from the REFER series from Bangalore, India. Today we will look at anomalies of ductus venosus and umbilical vein systemic shunts. Ductus venosus is a trumpet-shaped vessel which connects the umbilical vein through the portal sinus with the IVC. This facilitates shunting of 25% of oxygenated blood into the left atrium via foramen ovale with very high velocity, thereby bypassing the right heart. This protects the heart from the umbilical venous high maternal pressure and also dilates in hypoxia. This is the diagrammatic representation of the venous anatomy. You can see the umbilical vein coming into the abdomen. It takes a intrahepatic course normally, reaches the portal sinus, and from the portal sinus, this area which is shown in a brighter color is the ductus venosus, and this connects the umbilical vein through the portal sinus into the IVC. You can see that this junction of the ductus venosus with the IVC is very close to the hepatic vein. So this is the normal anatomy of the ductus venosus. We need to be mindful that from the umbilicus there is a smooth curvilinear course going into the mid-abdomen, into the liver, into the portal sinus, and then through ductus venosus into the IVC. So this is the normal anatomy. Now here we have the mid-sagittal color Doppler picture showing the umbilicus. That's the umbilical vein entering the abdomen, and that's the umbilical artery exiting the abdomen, and both of them come out through the cord here. So the umbilical vein initially goes below the abdominal wall and soon takes a curvilinear course, goes towards the inferior surface of liver, enters the liver, goes to portal sinus. From there you can see that this small aliased structure is the ductus venosus, which connects the umbilical vein with the IVC. The aliasing is the point where there is high velocity in the ductus venosus, and that's where the Dopplers are done to get the ductus venosus waveform. At 12 weeks you can see that when we normally do our NT scan, this is a picture which everybody should obtain at the 12-week scan, where you can see the umbilical vein coursing towards the liver and then just goes below or posterior to the hepatic vein and then enters the IVC, and that's the right atrium. So this point of aliasing is the ductus venosus. This is umbilical vein, this is IVC, this is hepatic vein, that's right atrium. On cine loop, you can see that this point of aliasing is the ductus venosus. Just anterior is the hepatic vein, proximal is the umbilical vein, distal is the IVC, which goes into the right atrium. The umbilical vein can also be seen in a semi-coronal image as shown here. This is the ductus venosus, that's the umbilical vein, that's the IVC, that's the hepatic vein, and this small segment is the ductus venosus. At 20 weeks, this is the umbilical vein, the ductus venosus, the hepatic vein, and IVC. On 2D, you can see clearly that the IVC is posterior, that's the ductus venosus, that's the IVC, this is right atrium. So you can see that the ductus venosus connects to the IVC and not the right atrium or the hepatic vein. This is another view showing the umbilical vein, that's the IVC. here blue, this is the hepatic vein, and this segment, the earliest segment, is the ductus venosus. So from all these pictures, what we should be mindful is that the umbilical vein enters the liver and goes to portal sinus. From the portal sinus, the ductus venosus emerges and then goes into IVC. At the junction of IVC with hepatic vein and right atrium, that's where the ductus venosus enters the IVC. Now we will look at anomalous umbilical venous drainages. Broadly, we can classify it into intrahepatic and extrahepatic. Now, if the umbilical vein goes into the liver and to the portal sinus, that is a intrahepatic drainage. But from the portal sinus, it can go into the right atrium via an extra vein, or it can go into the hepatic veins via an extra vein. So this is a intrahepatic anomalous umbilical venous drainage. In the extrahepatic drainage, the umbilical vein can directly go into iliac veins, into the mid IVC, renal veins, upper IVC, or right atrium or coronary sinus. So hence umbilical vein can anomalously go into the systemic veins outside the liver, which is an extrahepatic umbilical vein systemic shunt, or it can go into the systemic veins through the liver and portal sinus by an extra vein or shunt, which is a intrahepatic umbilical vein systemic shunt. So this is one way of classifying the anomalous umbilical venous drainage. So it can drain into the systemic veins either intrahepatically or extrahepatically, and this is called umbilical vein systemic shunt. In the extrahepatic shunt, it drains directly into the extrahepatic veins. In the intrahepatic systemic shunt, it can go into portal sinus, and from portal sinus there is a shunt from portal vein to hepatic vein or portal vein to IVC or right atrium. Now we will look at another type of classification, which is abnormal shunts. Type 1, type 2, type 3. So in type 1 is called USS, umbilical vein systemic shunt. So this is the umbilical vein directly shunting into iliac veins, IVC, right atrium, coronary sinus, and you can see that in this situation there is no ductus venosus. So it's a agenesis of ductus venosus. Type 2 is DVSS, ductus venosus systemic shunt. So here there is a ductus venosus which is small or abnormal, and that shunts into IVC or right atrium. So in this type 2, the umbilical vein goes into portal sinus and there is a abnormal ductus venosus in this type 2, the umbilical vein goes into an abnormal ductus venosus and then it can go into IVC or into the right atrium. So because of the abnormal ductus venosus, this is called ductus venosus systemic shunt. So this IVC junction will not be near the right atrium, it will be far away from the right atrium, or it could go into the right atrium directly through an abnormal ductus venosus. Type 3 is portal vein systemic shunt. So here we can have umbilical vein going to portal sinus and then there is no ductus venosus. The portal vein through one of its branches can shunt into hepatic vein or into IVC. Thereby it gets classified into intrahepatic or extrahepatic, which is type 3A, type 3B. So according to the shunts, the classification is type 1 when there is umbilical vein to systemic vein direct shunt. There is no ductus venosus. type 2, there is an abnormal ductus venosus. So it's a umbilical vein ductus venosus to systemic shunt, which could be either into IVC or right atrium. Type 3, there is no ductus venosus. The umbilical vein goes to portal venous sinus, and then from a branch of portal vein, there is either a portal vein to hepatic vein shunt or portal vein to IVC shunt. Thereby it becomes intrahepatic shunt or extrahepatic shunt. So this is another type of classification according to the venous shunts. So in all these classifications, whenever there is ductus venosus absence, it becomes agenesis of ductus venosus. So in this situation, we have to look for persistent right umbilical vein, anomalous ductus venosus drainage, portal vein agenesis, ASD, VSD, DORV, chromosomal defects like trisomy 21, 18, Turner's, etc. So whenever we deal with ductus venosus agenesis or umbilical vein abnormal shunts or ductus venosus abnormal shunts, there is a 15 to 20% chance of chromosomal abnormalities or single gene disorders. Hence, the role for amniocentesis and for microarray is or monogenic disorders is a requirement. Now we will look at cases. So first one is an umbilical systemic shunt. So in this case, umbilical vein drains into right atrium with an abnormal ductus venosus. So here you can see that the umbilical vein comes towards the liver, then does not go into the IVC at the level of the hepatic vein, but then proceeds and enters the right atrium, and at this junction there is an abnormal ductus venosus. So here you have the case. The umbilical vein is directly entering into the right atrium. It may look like it is entering the IVC, but we need to alter the scale. We need to use high frequency probes and look at the anatomy carefully, and you will realize that the umbilical vein is going straight into the right atrium. And this can also be seen by showing the portal venous anatomy, etc. And also we have to demonstrate the IVC and the right atrium. So you can see that the IVC goes into the right atrium. Normally we would have found the ductus venosus here, but we are not able to show the ductus venosus here. And when we look at the Dopplers, however, there is a classical ductus venosus type of flows at the place where the umbilical vein joins the right atrium. So this is a classification where there is a ductus venosus to systemic shunt, and here we have an umbilical vein RA shunt through an abnormal ductus venosus. So here you have the IVC flow, which is normal, and this is the 2D picture showing the umbilical vein bypassing the portal sinus, going directly into the RA. At the level of RA, there is a ductus venosus type of flows, so it is classified as the umbilical vein systemic shunt via ductus venosus. So this is a DVSS type of shunt. On color Doppler, you can see that the umbilical vein goes into the liver, and then instead of going towards the IVC much below the right atrium, it goes quite high up and directly into the IVC. So that is the shunt into the IVC via a small ductus venosus. On an axial view also, you can see that from the right atrium emerges out a vein which is actually the umbilical vein. As you can see it going tortuously outside, taking a turn and going out of the umbilicus. Now we will come from the umbilicus. Those are the two umbilical arteries, and that's the umbilical vein. Here it takes a tortuous course, and then the umbilical vein enters into the liver, and once it comes into the liver, you can see the hepatic veins there. It goes directly up, and it remains in the center, and you can see that it enters the right atrium as shown here. Now here you have a torso anterior position showing the umbilical vein and directly going into the right atrium without entering the IVC. That's the IVC right atrium junction, and anterior to it you have the umbilical vein entering the right atrium. So this is a example where umbilical vein goes into the right atrium. Now we come to another example, which is again a umbilical systemic shunt. Here the umbilical vein drains into IVC. So the prior example was umbilical vein draining into RA via an abnormal ductus venosus. Here we have umbilical vein draining into IVC without ductus venosus. So this is a direct entry of the umbilical vein into the IVC. You can see that the distance would be away from the hepatic vein. That is the clue which you have to pick up. So here we have the umbilical vein coming towards the heart, but it enters the IVC as shown here. You can see that the umbilical vein is entering the IVC, and you can see here that's the umbilical vein and that's the IVC. Umbilical vein enters the IVC. So in this case there is no high velocity ductus venosus flows here. So here in this case there is no ductus venosus. This is a USS or umbilical vein systemic shunt going directly into IVC. Now we will come to another example, which is a umbilical vein systemic shunt again, but here the umbilical vein will drain into IVC with an abnormal ductus venosus in between. Okay, so here you can see the umbilical vein directly entering into the IVC, but at this location when you do Doppler you will get classical ductus venosus waveforms. So this is the example where you can see that that's the umbilical vein. It takes an abnormal turn here and enters the IVC. Look at the location of entry of the umbilical vein to the IVC. It is far away from the right atrium and far away from the hepatic vein confluence. So this is an umbilical vein IVC shunt. So it's an umbilical vein systemic shunt. But then when we interrogate, this is another view showing the umbilical vein entering into the IVC much away from the right atrium. This is when the fetus is in a dorso-anterior position. The previous one was when it is a dorso-posterior position. So in the axial view, you can see the umbilical vein going straight towards the liver. You can see the hepatic veins here. It directly goes and shunts into the IVC, and we can see that it is a direct umbilical vein to IVC shunt. So in this case, the portal veins were completely absent. So here we have a beautiful mid-sagittal plane where we have the umbilical vein coming towards the into the liver. Instead of going towards the heart, it chooses to go straight down into a mid IVC. That's the hepatic vein, that's the right atrium, and look at the distance from the right atrium and hepatic vein from the umbilical vein IVC confluence. And here we have aliasing, and at that point when we do a Doppler we get a classical ductus venosus waveform. So once by seeing the ductus venosus, it does not mean that the anatomy is normal. So this is the turning point here. Ductus venosus waveform, which is demonstrated in first trimester, does not rule out anomalies of ductus venosus and anomalies of umbilical vein systemic shunts. So in the first trimester, even if you show a ductus venosus, make it a point to demonstrate the ductus venosus in the second trimester, when you will be surprised that you will pick up these type of venous anomalies. So here we have an umbilical vein shunting into IVC, and at that point there is a ductus venosus, but the shunt is much below the right atrium and hepatic vein. That is why this becomes an abnormal umbilical vein shunt. And in this case you can see that because the shunt goes directly into the IVC is significantly dilated. So this was the clue with which I did the whole thing. So when I did my routine TIFA scan, as a part of TIFA scan I always do fetal echo. As a part of fetal echo, the hammock view or bicaval view is done, and in the bicaval view I found the IVC to be dilated. When I was trying to find out why is the IVC dilated, I realized that the umbilical vein is shunting into the IVC. But when I did Doppler, that point showed ductus venosus flows. So the classification becomes umbilical systemic shunt through an abnormal ductus, so it becomes a ductus systemic shunt. This is again another view showing a dilated IVC. That's the SVC, that's the right atrium, that's the IVC. That's a significantly dilated IVC because there is an abnormal shunt of the umbilical vein into the IVC. Even though ductus is present, it's an abnormal ductus, so probably the shunt is higher here, so that causes a overload. In this patient also there was a discrepancy between the right and left heart. You can see that the RVOT is normal, the LVOT is small. Now we come to another case which is a portal systemic shunt, and it's a intrahepatic type of shunt with agenesis of ductus venosus. So here we have umbilical vein entering the portal sinus normally. Then we don't see the ductus venosus. Instead we see the right portal vein shunting into right hepatic vein. So this is a portal systemic shunt with agenesis of ductus venosus. So here you can see that the umbilical vein comes as usual, joins the portal sinus, but then there is no ductus venosus going towards IVC. Then when you do the Doppler, you realize that from the right portal vein, an anomalous or an abnormal shunt is going and taking the blood to right hepatic vein, and then the blood goes into IVC. So this is a ductus venosus agenesis with a portal systemic shunt, and this is a portal systemic intrahepatic shunt. So here you can see that in the cross section of the abdomen, there is inside the liver, there is an abnormal looking tortuous venous structure. Now when we'll see what is this venous structure. This venous structure again has turbulent flow resembling a ductus venosus, which is not a ductus venosus but a shunt between portal vein and hepatic vein. So here you can see that umbilical vein enters the abdomen, goes to the liver, goes towards portal sinus, but blindly ends into portal sinus. It does not communicate with the IVC at all. So that is the clue which you have to pick up. This small bit of aliased portion of the vein which we learnt as ductus venosus is absent in this case. So the umbilical vein goes into portal sinus and takes all the blood into portal veins, and the hepatic vein goes into IVC, and the junction is not visible. And then what happens? You search what is happening. You move your probe to the left and right, then you see this abnormal shunt going from right portal vein into right hepatic vein. In a sagittal view, it is difficult to understand how I have told this as right portal vein into right hepatic vein, but in this axial view you will clearly understand the anatomy. That's the umbilical vein that goes into portal sinus, that's left portal vein, that's right portal vein, and you can see that from the right portal vein you can see a shunt emerging. This is the shunt, and this goes into the right hepatic vein, that goes into the confluence of the hepatic veins and into right atrium. So this is a portal systemic shunt in a case of agenesis of ductus venosus, and this shunt is understandable in this axial view. In the sagittal view, it is clearly understood ductus venosus is absent. In the axial view, we can show clearly the shunt between the right portal vein and the right hepatic vein as shown in this example. This is another color Doppler which shows the hepatic veins, and that's the right middle hepatic vein, that's the right hepatic vein, and from the right hepatic vein, that's the shunt going anteriorly into the right portal vein. So that is the portal systemic intrahepatic type of shunt. From the classification, it is type 3A, and this is the umbilical vein, that's the right portal vein, that's the shunt, that's the hepatic vein, and that goes into the right atrium. So friends, we have looked at umbilical vein, systemic vein, shunts, and agenesis of ductus venosus associations. Classifications can be based on the shunts. Classification can also be based on the ductus venosus, based on whether the shunt is intrahepatic or extrahepatic. And whenever the shunt is extrahepatic, the liver is deprived of its flow and there will be portal venous agenesis which can hypoplasia or agenesis. So whenever you have these anomalies, look at portal vein anatomy, and in one of our examples which I have shown, there was portal vein agenesis. This makes it very serious, as there can be cirrhosis in the neonatal or childhood period. So do not neglect umbilical vein, ductus venosus, hepatic veins, portal vein, IVC anatomy, because this can be a serious anomaly. And by showing a ductus venosus in first trimester, there is no guarantee that you have a normal venous anatomy. In the second trimester, we have to show whether ductus venosus is present or absent. And then we have to show whether umbilical vein shunts into the portal sinus and IVC, or whether it shunts directly into systemic veins or via a ductus venosus, or there is a portal systemic shunt which replaces the flow. Thank you very much for your patient learning. This is a little difficult topic. I request you to look at the videos and the classifications and the drawings multiple times in order to master this subject. REFER is the series called Radiology Education for Enhancement of Radiologists, and that is my number. People wanting to do masterclass, which is a online certificate course in fetal echo. There is also a class on aneuploidy that you can contact me and learn further. Signing off from Bangalore, Dr. Pradeep Srinivasan. Happy learning. Jai Hind.